I consider this probably one of my most important jobs that I have nowadays. As you get older and farther in your career, it's taking care of patients and doing good patient care is better, but I think it's really more about passing on education and experience to the next generation. And looking around the room, you're all the next generation compared to me. So the importance of this is really important to me. To you guys, that's just another lecture. But to us old guys like Dr. Gill, passing along our experience and our education will have a far further reach and profound impact on patient care than what I do every day. By educating and training all of you and helping you achieve your professional goals, you'll then go out and treat many, many more patients than I can ever expect to. And hopefully you will take this level of professionalism to heart, and then you become the teachers and trainers of the next generation. So it's really important to me. My Asperger's, as most of you know, will impact these lectures, these sorts of educational lectures. I can seem intense, and I can seem demanding, and I can seem belittling. I absolutely feel that you guys know very little about what I'm talking about, even though it's a very common disease. Atherosclerotic cardiovascular disease is something that you deal every day. In that I will ask questions. I will not be asking questions that I expect you to know the answer to, but I will ask the question and I expect an answer. You may seem that as belittling and lowering, but I want you to think, and I want you to say, well, that's the question, what do I think and guess, and then I'll tell you the right answer. You might guess right, which is good. But my intent is purely educational. I really would like questions. Interruptions are almost always appropriate and dealt with in an appropriate manner, so please feel free. This should be low-key, conversational, and discussion. That being said, I don't think I did a disclosure slide, which is important for CME. I did not do a disclosure slide, but I have no disclosures that would impact this talk or be a conflict of interest. So that being said, now we're on tape, so that's as good as a slide. That's a nice slide, isn't it?
Mm-hmm. I like it.
What we're going to talk about is atherosclerotic cardiovascular disease. It was labeled coronary artery disease, but unfortunately with my Asperger's, I can tell you that coronary artery disease is way too general of a topic because there are other things, other diseases that affect coronary arteries. But I think what we want to hit here today is atherosclerotic cardiovascular disease, your standard bread and butter, cholesterol blockages of the coronary arteries, hardening of the arteries, all that stuff that we have been working on forever. I'm going to digress here quickly just to give you an interesting story. Anybody know the story of how we figured out that acute coronary syndromes and STEMIs were related to blood clots? And hence thrombolytic therapy and then PCI? STEMIs were recognized as virtually a death sentence. Patients would spend 3 to 6 weeks in the hospital, and many would die, particularly with large anterior infarcts. The only form of therapy that was really early on was cabbage. But the ability to get people into the OR and get revascularization done in their STEMI in a timely fashion, and getting the OR set up, the surgeon, anesthesiologist, perfusionist, things like that, was incredibly complex and cumbersome. There was a small hospital on the West Coast that dedicated themselves to improving the mortality from coronary artery disease, and particularly in STEMI. So they developed a team approach and got it so that they could get a patient within 24 hours of their presentation into the OR and perform bypass surgery. A young cardiologist and cardiovascular surgeons that were involved in that noticed that 17 out of 20 of the first patients, when they opened up the coronary artery to do the anastomosis, they took out huge clots, long worm-like clots out of it. it was a game changer, because previously to that, our understanding of STEMI was not blood clot. It was that the blockage had grown so severe that then there was a mismatch of supply and demand. And that mismatch got to the point that demand was way outweighing the supply, and patients had an infarct and a STEMI. That was common. That was what we knew. That was verbatim. That's the talk that would have been given to you in the early 70s, that is the cause of ST segment elevation myocardial infarctions. And it wasn't until we actually opened up and then we go, huh. So some of the things I will tell you here today, and I will tell you with absolute certainty that this is the truth. You guys 20 years from now might say, well, that's what we used to think, but now we know the truth. So let's talk about workup of chest pain. So these patients are going to come to you in the clinic. This is primarily an outpatient talk because ACS is on April 7th, so that'll be the inpatient talk. But patient comes to you either for follow-up of their ischemic heart disease or a new workup of chest pain. This is all you really need to think about is history and physical. That's important in everybody. An EKG, we'll talk about testing. They need a CBC. Why do they need a CBC for workup of angina or chest pain? Yeah, I can take any of you and drop your hemoglobin to 4 and probably give you angina. So we find GI bleeds all the time in the office just by checking a CBC. I throw this up here because very, very few cardiologists, and therefore I think very, very few APPs, cardiovascular APPs, should ever order a coronary calcium score. It really is not useful and the guidelines don't recommend ordering coronary calcium scores. It can be done in some cases, but really it is of no benefit. It's great promotional for hospitals. It does get patients to think about their heart and ultimately gets them in to see you so you can do important things like lowering their blood pressure, diagnosing diabetes, lowering their cholesterol, getting them evaluated. But I think it's still, for general population, it's still a class 3, meaning don't do it. There's no indication for coronary calcium score. And that's why it's out of the pocket. That's why when you go to get your coronary calcium score at screening at the hospitals, it's $39.99 or $49.99. It's because it's out of pocket because the insurers and CMS ain't going to pay for a coronary calcium score because it's class 3. We can discuss that more if anybody wants to, because it's a interest of mine is why these get ordered and how they get ordered, and then how do we deal with the data that comes up. But somebody comes in with chest pain, don't order a coronary calcium score. Although I know it's done in Prairie, not on a daily basis, but not too infrequently. This is important. Clinical classification of chest pain. Everything we do on a daily basis involves communication. You telling me what the patient has, me telling the next doctor down the line what the patient has, and we all got to speak the same language. So if you tell me somebody has, they presented with typical angina, well, what does that mean? Well, typical angina, this is the official definition, is substernal chest discomfort with a characteristic quality and duration that is provoked by exertion or emotional stress and is relieved by respiratory nitroglycerin. That is a simple definition. And when you come to tell me that somebody has typical angina, I know exactly what you're talking about because we are talking the same language. So instantaneously, I know what you're thinking, I know what the workup should be, I know where we're going, and I don't have to catch up later if I find out that we're miscommunicating. So that's the typical angina. Well, what's atypical angina? Meets 2 of the above characteristics. I mean, it's got most of the stuff up here, but not all the stuff up here. Maybe they don't have substernal chest discomfort. Maybe they just have exertional dyspnea, but it's provoked by exertion or emotional stress, and it's relieved by respiratory nitroglycerin. That's atypical angina. You come to me and say, this patient has atypical angina. Again, I know exactly what you're saying, and I'll be able to jump to the end of the story and know where we're going with this patient. I'm with you. I'm listening to you. I'm delving in deeper. Finally, non-cardiac chest pain can meet one or none of the typical anginal characteristics. So if they got substernal discomfort but none of this stuff, it's likely to be non-cardiac chest pain. So these are important, and I'm going to delve into these a little further. Typical angina, it's a discomfort more than it is a pain. Their patients will often correct you in the office or in the ER. It's not a pain. They keep calling it chest pain. That nurse keeps asking what my pain is. I don't have any pain. Well, you're having discomfort and you've got 4 millimeters ST segment elevation on your EKG. We can call it whatever you want. You're having a heart attack. But patients really are fairly adamant about that, and I think you have to keep that in mind. And some patients become somewhat insulted when you keep calling it chest pain, because it's not chest pain in their mind. It's more of a discomfort. It can be a squeezing, a tightness, a pressure, a burning, an ache, a fullness, or a heaviness in the chest. These are the most common descriptors when you look at randomized trials and also registry trials. It's usually not sharp. It's usually not stabbing. It's usually not fleeting, meaning there. It comes and goes that fast. Comes and goes that fast. Usually not typical angina. It's not affected by inspiration, cough, position, change, or palpation. If patient, I got chest discomfort right here, and you push on their chest. Oh, doc, that makes it worse. Okay, this is not typical angina. Okay, this is not typical angina. And it's important to remember these things, and when you're working up patients, that if the discomfort is affected by these things, it's probably not typical angina. It's also not pinpoint. Patients can't take one finger and say it's right here. They'll do one of these, or the classic Levine sign. It's not focal and pinpoint. So that's important to remember about typical angina. The radiation patterns, we all know, the shoulder, arms, neck, throat, jaws, back. Rarely the upper abdomen. This is always hard for us to figure out because it esophageal reflux, is it peptic ulcer disease, what have you. But shoulders and arms, neck, throat, and jaws, ding, 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 ding. Feeling pretty good about that. So these are all further characteristics of typical angina pectoris. It's provoked by anything that increases myocardial oxygen demand, anything that the heart needs more blood and can't get it through because of a blockage is going to set off typical angina. So any activities, any tachycardia, patient going in out of AFib or an SVT, patient comes in and I only have when I feel my heart going fast, and then a few minutes later I get that discomfort right here, doc. Boom, the tachycardia is increasing myocardial oxygen demand and causing a supply-demand mismatch and causing angina. Blood pressure elevation, yeah, doc, when my blood pressure is really high, I get that discomfort. Ding, 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 ding. This isn't just high blood pressure. This may be an underlying blockage that when their blood pressure goes up, their myocardial oxygen demand goes up, they get angina. As per the definition, it's relieved by rest and nitroglycerin or resolution of the tachycardia, resolution of the BP elevation, etc. Associated symptoms, classically shortness of breath or dyspnea, nausea, vomiting, diaphoresis, and fatigue. This one, you got to ask. I just feel more tired with activity than I used to, doc. I think it's just because I'm getting old. Well, when did it start? About 6 months ago. Well, you're 80 years old. You've been old for a long time. This ain't because you're getting old. Something's changed. Generally lasts 2 to 4 minutes because the discomfort is to the point that patients don't like it, so they stop what they're doing and the symptoms get better. This got cut off. I don't know why. But definitely less than 20 minutes. If the pain goes on 20 minutes, we're moving out of typical angina and into myocardial infarction and acute coronary syndrome. Atypical. No.
Yes.
No.
Yeah.
What?
Okay, so the other thing is with your rest and nitro, one thing I would just kind of add, typical is not that I rest or I take a nitroglycerin and an hour and a half later it goes away. That's not typical.
Excellent point.
Because we get that all the time. Okay, I took 20 nitros and it went away halfway through the day.
Great point. And I took the nitroglycerin and it hasn't gone away. Well, how long ago did you take the nitroglycerin? About 30 seconds ago.
Yeah, exactly.
It's a little time.
Yeah.
So 5 minutes is typically the time period that you want to think that they start getting some relief with these. That's a great point. I will add that for next year if you have me back.
Yeah.
Atypical angina has some, but not all of the features of typical angina. And we discussed dyspnea equivalent angina, no chest discomfort, but they just get it in their jaw, they just get it in their arm, or they just get it in their back. But it's reproducible with exertion or reproducible with emotional stress, and it gets better when they rest or better when they take nitroglycerin. I know this for certain because my mother, who is married to a cardiologist and whose son is a cardiologist, said, God, every time I take the garbage out, my shoulder's hurting. My arthritis is worse. I said, Mom, I don't think that's your arthritis. No, I'm sure it's your arthritis. She delayed, and you can't make her do it. My father and my sister's a physician. We don't think that's your arthritis. That's my arthritis. Smoker, family history, and all. And she never got worked up. The cobbler's kids never got worked up for her shoulder pain with exertion, and rolled into the ER with an anterior stim. Did well, but ultimately died of her coronary artery disease. Would diagnosing her early changed her long-term outcome? Probably not, but maybe she could have taken the garbage out more easily. But that is somebody who had no chest discomfort, really didn't have any shortness of breath, although she had big-time COPD and was always short of breath. Maybe she just didn't notice it. But she just had shoulder pain, left shoulder pain when she exerted herself. Atypical angina can be sharp and stabbing. I think this comes down to patients interpreting their symptoms, and that's what it feels like to them. But yeah, I get the sharp chest pain right here, doc, right in the center of my chest, every time I walk up a flight of stairs. That's not typical angina, but it sounds like atypical angina. I would be happy if you said, yeah, that sounds like atypical angina. They get a discomfort in the center of the chest. It's described as sharp. It comes on predictably with exertion, and it's predictably relieved with rest. I'll go, yeah, I agree with you. It sounds like atypical angina. Instantaneously, I know what you're saying. I can interpret it, and we can work together about what the next steps are. So I think that, again, going back to the definitions is important. Non-cardiac chest pain. Musculoskeletal pain is focal. It's reproduced with palpation or movement. Every time I move my arm, doc, I get that pain in my shoulder. Well, that's probably rotator cuff, okay? It's not your heart. Patients will have trauma or overuse injuries with this as a precedent that you can ask for. GERD is usually burning. It's located in the lower substernal upper gastric area. Can occur postprandially, relieved with antacids. Sour brash in the back of the throat, things like that are tip-offs. Pleuritic pain is often sharp. They'll say it's a sharp pain, and it is a pain, and it's sharp. It's worse on inspiration or cough. So the patient with bronchitis or flu recently, and oh man, doc, I got this chest pain now. I've had it for a couple of days. It comes and goes. Well, is it worse when you take a deep breath? Well, I don't know. We'll take a deep breath. Oh yeah, that brings it on. Ding, ding, ding. Not their heart. Non-cardiac chest pain. Pleuritic pain. Pleuritic pain is often seen, also often seen with pulmonary embolism, so something to keep in mind. The rest is self-explanatory. Pericardial chest pain is hard for patients to qualify. They say it just hurts. It can be very severe. Some people call it sharp. It often is positional or pleuritic, the adage of making the patient lean forward. Sit up and lean forward actually throws the heart up against the anterior pericardium and causes more pain. Taking a deep breath shifts the heart and the heart border inside the pericardium, so it can make it worse. It's usually the anterior chest. It often radiates to the trapezial ridge, which is your trapezius and your shoulders. That's a classic. I only see the classic in acute pericarditis maybe 20% of the time. But sometimes that can be hard to differentiate between angina and pericardial pain, because they have chest pain, it's center, it's sharp, it's really severe, and it's radiating up, some would say, to the shoulders, or at least the trapezial ridge. And it can be very difficult to differentiate the two, and you got to be open to both diagnoses. And the other thing about today is you don't have to be right. This is an art, not a science, in evaluating these people. We make it look easy because John Gill's been doing it 30 years. I've been doing it 25 years. And we make it look easy because we've seen 1,000 patients a year and done this, so it gets easier with time. But you're allowed to be wrong, but you aren't allowed to not consider all the differentials and move on when the data is not supporting your initial diagnosis. Aortic dissections, once you've seen one, you'll understand it. It is severe. The patients are writhing with how severe this is. Tearing or ripping pain, usually in the back, in the center of the back between the scapula. It can be anterior, but these patients are sitting up, they're moving on the cart. Anginal patients, they are moving a lot because they don't feel good, but acute aortic dissections hurt really bad, and it is sharp and it is bad. So you look at the EKG, and the EKG doesn't show ST segment elevation, yet this patient has severe pain and they're writhing on the bed. Ding, 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 ding. This patient needs to get a CT or TEE or whatever imaging modality you want, because they're likely having an aortic dissection. Pulmonary embolism, we talk about, already talked about, it's often pleuritic. They'll often have significant dyspnea or shortness of breath, usually acute in onset, but not always. Atypical chest pain. That's something we didn't define or characterize. Go ahead. Someone define atypical chest pain for me. Seriously, somebody has used that term yesterday or the day before.
I use it all the time.
Yeah, so define it. Because this is about communication, so
Right.
define what you mean by atypical chest pain.
So to me, patients will come in and they'll say, I was out working in the yard, I did all the sticks and everything, and then I came in and I had this chest discomfort, and it was in my chest and it radiated down both arms, then it went through to my back, then it went down my left arm, or left leg, and then I laid down for a while, and then it went away, and I woke up the next day and it was gone. So to me, that's
I don't know, I would say
typical
that's
and atypical.
had chest discomfort with typical radiation patterns.
Yep.
They came on with exertion and finally went away, but it didn't meet all the criteria for typical angina.
Right.
Why isn't that atypical angina?
Well, see, this is where now looking at
Okay.
your definition, that's where I always do that wrong then, because
And
I
I'm
always
gonna-
say typical and atypical.
This is a pet peeve of mine because
Yeah.
it was pounded into me as a med student, intern, and resident cardiology fellow
Yeah,
by my program directors, and I agree with it. We define typical angina.
mhm,
And once you define typical angina, defining atypical angina is simple. It doesn't meet all the criteria, but it has some.
What about
Hey, wait. So atypical chest pain, so let's look at that in the way we look at atypical angina. So in atypical angina, we define angina, and then we say it's atypical, it doesn't meet all the criteria. Define chest pain. You can't.
Yeah, you should report it.
Because chest pain is such a ubiquitous, vague term. So if you can't define chest pain, calling something atypical chest pain doesn't help me. So, but it's used every day. It's used every day in Prairie. It's used every day across the country by a really good cardiologists, but it's a sloppy term. You come to me and I have a patient with atypical chest pain, and I'm going, I have nowhere to go. You come to me and say, I got somebody who has most likely non-cardiac chest pain. Okay, I know where we're going. I'm going to look at their risk factors, consider do they need a stress test, or is this really non-cardiac chest pain? Or they have atypical angina. Ding, ding, ding. We need to start thinking about stress testing. Or they have typical angina. We need to start to. But when you tell me somebody has atypical chest pain and on the phone, I'm busy, I have no idea what you're trying to describe, because I cannot define typical chest pain. And if I can't define typical chest pain, I sure as hell don't know what atypical chest pain. And your description might be a billion times different than mine. Go ahead, I interrupted. Yes?
Can I say that I'm scared to use angina in
So don't be
documentation?
scared. You're allowed to be wrong.
I think I'm scared to use it because unless I know they have documented CAD, I don't want to say it's angina, then be wrong and look stupid.
Exactly. And that is the number one mistake of all nurse practitioners, nurses, med students, residents, interns, fellows. Everybody's scared to be wrong. Our entire educational lives have been you're either right or you're wrong, and we don't like being wrong because being wrong is bad. In medicine, it is much better for you to say, evaluate the patient, use the definitions, and say, well, you know what, this meets the criteria for angina. If you're wrong, and it's not angina, well, good news. Patient doesn't have angina. That's good. But if you're right, and you get the appropriate tests done and implement the appropriate treatments, you may have saved a life. But being scared to call it angina because you're afraid it might not really be, you may miss doing the appropriate test and may miss getting things done, and you may kill someone. So when you come to me and say, I don't know, and don't use the word angina, then we're back to that communication thing, and I don't know what you're really thinking. And if I don't know what you're really thinking, I can't help you to where we're going with the patient. And it's okay to be wrong. How many normal heart caths do we do in Prairie every day? A few. And that's okay too. In fact, I always tell patients that, I'm so happy. I've just given you the best news in the world. Your risk of cardiovascular death is dramatically lower because you have a normal heart cath. They feel good about it. I feel good about it. And if we follow the appropriate guideline-directed therapies and testing, we did everything right. We're operating on all the science and research ever done. We came down to the right testing, and we were wrong. Hallelujah, we were wrong. I mean, it's okay to be wrong in this. It's really not okay to miss a diagnosis. But you're not alone. Everybody in this room, myself included, is afraid to be wrong and afraid to call something angina when it's really not. But if you use the definitions that we discussed, no one can throw a stone at you. Because you can say, well, you were wrong, it wasn't angina. Well, no, by definition, it was angina. The patient just has normal coronary arteries, and there's another source for their chest pain. So don't feel bad about it, but you will, but you'll get over it. When you get to be my age, people don't throw stones at you being wrong as much. They still do. Other questions?
So what you're saying is every time somebody meets qualifications for atypical angina, obviously we'd have to take the patient into consideration and their history and things.
Lots more into it than just yeah.
We should take that more seriously than if we were to be leaning towards the...
Atypical angina is just as bad as typical angina. It means that
So unless we're absolutely certain it's non-cardiac chest pain, if they have, 2 of the 3...
It should be worked up as angina.
And we should stop I get, because I
You
do
should
this all
stop
the
using
time,
atypical chest
I should
pain.
stop using the word chest pain.
Yeah, I do too.
Well, you can use chest pain, but you don't...
In the right,
Not as
by
far
the
as
initial
non-cardiac
definition,
chest
by the initial,
Non-cardiac chest pain is a great diagnosis.
yeah.
And important. So
Yeah.
atypical chest, if you can't define it, you can't use it. If you guys come up with a universally agreed upon definition of atypical chest pain, then you can use it and give it to me because I'll use it too. But there is no universally accepted definition of atypical chest pain, which means you are going to promote miscommunication
Okay.
by definition.
God, I do it every day.
This is a great slide. This is a very old slide. The CAS data comes out even before I was in practice. But this looks at age groups, the 30-year-olds, 40-year-olds, 50 and 60-year-old, looks at patients with non-anginal chest pain and patients who have atypical angina and typical angina. Well, if you're a 30-year-old and you've got non-anginal chest pain, there's only a 4% chance you're going to have significant coronary artery disease of catheterization. Alternatively, if you're 30 years old and you have typical angina and you're a man, there's probably a 76% chance that you have angina. So clearly, just your history alone in a 30-year-old patient presenting with chest discomfort, you can make the odds swing in your favor. Do I think this is non-anginal? 4% chance you're going to be wrong. Or I think it's angina, 76% chance you're going to be right, which goes back to not wanting to be wrong. Not wanting to be wrong. Everything we do every day is a crapshoot. We're gambling. And the way you beat the house is to have more data and understand the odds. So if you understand that a typical angina in a 30-year-old, even though they're only 30, but they have a 76% chance of having significant coronary artery disease at cath, boy, you just beat the house. Because the dumb schmuck next to you doesn't know the odds, they'll bet, well, he's only 30 years old, this isn't heart pain. You're going to beat the house because you know that 30-year-olds with typical angina in a man, 76% chance that it is real coronary artery disease. So you're going to beat the house. Women, look, only 26% chance. So a 30-year-old who has non-anginal chest pain, 2% chance of coronary artery disease at cath. But if they have typical angina, 26%. Still significant, but these guys you're more likely to be more aggressive in because look at the odds. Women less aggressive until you get up into the older age. We know that the progression of heart disease in women and their presentation is often delayed for reasons we don't understand. It's probably just God punishing men, I don't know. But this is an important slide showing the differences just by the first three definitions we talked about, non-cardiac chest pain, atypical angina, and typical angina, and putting that together with an age, you're beating the house. You know the odds. So a 65-year-old man with typical angina, 94% chance they're going to have coronary artery disease. That's dramatic. You know, right there, if we all got 94% on all our tests, we'd be rich and famous, right? I mean, it'd be great. You're getting an A on every test. So I like to cheat. I like to know the answer before I take the test. So 65-year-old man, typical angina, I know what you got 94% of the time, and I'm okay being wrong 60% of the time. This is similar data, but it looks at, down here you got to read. These, the first value, the lower numbers, are patients that have no other risk factors, meaning without diabetes, no smoking, no hyperlipidemia. The second figure in each one of these columns is that a patient with diabetes, smoking, hyperlipidemia, and all these patients have a normal EKG. So once again, if you take, give me a patient who is 45 years old with non-anginal chest pain with no risk factors, there's only a 9% chance they're going to have coronary artery disease. But if they've got multiple risk factors, diabetes, tobacco abuse, hyperlipidemia, and they're 45 and they're a man and they have non-anginal chest, boy, about 50-50 coin toss now. So again, using these ideas, you're going to know, and it's always better to know what a patient has before you do any test on them. It makes you smarter, makes you look better, and this is what all old cardiologists are doing. We know these data, and we're factoring this in. This is why we're right more often than we're wrong. And you can see a 65-year-old male with risk factors, 97%. And I think the important thing is how dramatically it changes the percentage of women with coronary disease who has typical angina. So really, if a woman has typical angina and multiple risk factors, regardless of her age, now we're moving into approximately 80% chance she has significant coronary artery disease. So type of pain, non-cardiac, atypical angina or typical angina, their age, their sex, and then risk factors all let you beat the house. You can go to Vegas and come home rich because you know the odds, and even before you do any testing. You know, we aren't talking about anything other than you did an EKG, which is normal, and then you did a history and physical, and now you're already knowing what the patient has. So history and physical is critically important in these, and is not. Down here you'll see if ST and T wave changes or a Q wave on their EKG, the likelihood of coronary artery disease would be higher in each entry of the table. So these are patients with normal EKGs, some without risk factors, some with risk factors. I think that's really important, and hopefully that's enlightening to you, that your history and just defining if this is angina or not, and knowing the age and knowing their sex, you're already making the diagnosis. Damn Canadians, they came up with their own classification of angina.
Just one beyond the map.
Interesting, the lead author on the article, which, what's that say, 76, came out in 76. Lucien Campeau, who died 3 years ago now. Lucien's actually a radiologist, and Lucien Campeau is the originator of transradial cardiac catheterization. So it was great. So I have to point out that he also was the lead author on this. And again, this is for communication issues. If you tell me somebody with atypical angina with grade 1 CCS class angina, I know exactly what you're talking about. They've got not all the characteristics of classical angina, but 2 out of the 3, and it only comes on when they're really under strenuous or rapid prolonged exertion. With just one simple sentence, I know exactly what you're trying to describe to me. I know how to treat that, and I know how to go ahead. So being able to classify and being good in your language is important. Is everybody familiar with CCS classification? So class 4 is rest or minimal activities. Grade 3 is with daily activities such as climbing stairs or just routine household activities. Moving on to treatment of these chest pains and angina. When that patient's in the office and you feel this is angina, be it typical angina or atypical angina, don't wait for the stress test or heart cath to come back. Start them on an aspirin. Low risk, cheap, might save their life. Start them on a beta blocker. Start them on a low dose, but why wait to treat? If this is a patient who you really are calling angina and we looked at the risks of your description, the patient, depending on their age and sex and risk factors, if you really think that this is angina and there's a 75% chance in this 40-year-old woman that this is truly angina, why wait for the test to come out? You can always stop aspirin, you can always stop a beta blocker, and you can always not refill a nitroglycerin prescription. These are cheap, easy, and I don't think you should wait for a complete, accurate diagnosis to start therapy. Risk factor modification, you guys all do this well. Tobacco cessation, hypertension, hyperlipidemia, this will go on in that first visit as well. Other anti-angial, start with a beta blocker, but if you're seeing back in follow-up, you can include chronic nitrates, or they come to you and they're already on a beta blocker and you think they got angina, maybe then add in a chronic nitrate or calcium channel blocker. I'd probably wait on the Renexa, but there's no harm. It's just really expensive. These come right out of the guidelines. Shar always likes it when we educate you as per the guidelines, which we should. If you follow the guidelines, even if you're wrong, no one can throw a stone. You are following the guidelines and should follow the guidelines. And if you're wrong, even if the patient has a terrible outcome, you were following guideline-directed therapy. And you cannot be held liable for that. You are doing the right thing with the data we have, so it's always good to follow the guidelines. So this comes right out of the most recent guidelines update. SIHD is, oh my God, stable ischemic heart disease, sorry. So this is your anginal patient. Should be based on strong scientific evidence, blah, blah, blah. Presenting with angina should be characterized as stable versus unstable because the treatment strategies are different. Today we're talking about stable. Those at moderate or high risk should be treated emergently with acute coronary syndrome. That would be unstable. And then they go on and say a standard exercise test, read treadmill test, is the first choice to diagnose ischemic heart disease for patients with an interpretable EKG and who are able to exercise. So the guidelines say you should do treadmills on everybody. The last time Prairie did a plain vanilla treadmill, it's probably a long time ago. It just doesn't happen. We can discuss why that is. But you guys should be aware that the guidelines recommend that to diagnose ischemic heart disease, so that patient that comes into your office with chest pain that you think is angina or atypical angina, and they have an interpretable EKG, meaning no ST or T wave abnormalities that will preclude an interpretation of the stress EKG, and they're able to walk on the treadmill, they should go on to have a plain old vanilla treadmill. If it's uninterpretable EKG, then you move on to your SPECT or your echo or even cardiac MRI. If they're unable to exercise, then you can give pharmacologic therapies. This is what you guys don't see, and we don't practice guideline-directed therapies, but I tell you, insurance companies, a lot of times we order a nuclear stress test with a normal EKG and a patient able to walk, or even, heaven forbid, a Lexiscan cardiolite, in patients who can walk, who have a normal EKG. The insurance company often only reimburse Prairie for the plain old vanilla treadmill. And you really, by the guidelines, by the data we have, you can't argue with them. They are right. But you should know that. Patients already diagnosed with ischemic heart disease. They had a 50% stenosis at cardiac catheterization. You're following up with them, and they're having a little chest pain. This is assessment of risk. We already have the diagnosis, but we're assessing their risk for death or complications. And again, with an interpretable EKG, who are able to exercise, treadmill. Those who don't have an interpretable EKG, then you can go on to echo or nuclear or cardiac MRI, and if they can exercise, then you can give them pharmacologic stress. So you guys will go out there today and be ordering tests that are clearly inappropriate to the guidelines. Do that at your own peril, but document reasons why you think imaging modality is important for this patient, because that's going to be more important moving ahead in our geopolitical climate. Patients with the disease receive a package of guideline-directed medical therapy, diet, weight loss, activity, smoking cessation, aspirin, statin medication in a moderate dosage, and hypertensive control and glycemic control. As we said, patients with angina should receive sublingual nitroglycerin and beta blocker. When these are not tolerated, or the beta blocker is not tolerated, you can use verapamil or ricardizine or a long-acting nitrate. Coronary angiogram or left heart cath is only considered for patients whose clinical characteristics and results of non-invasive testing indicate a high likelihood of severe ischemic heart disease and when the benefits are deemed to increase risk. Any questions on that? Because we don't always follow this. Now, I think you can say if you got a patient, 65-year-old male, multiple risk factors, abnormal EKG, who presents with typical angina. Elephant sitting on my chest, goes down both my arms, short of breath, comes on with me getting up and walking to the bathroom dock. It's been there for a week. I can't do anything. What are the odds that this is coronary disease?
95%.
I put 99%. You're going to be right 99% out of 100. If they have a stress test and the stress test says, nope, it's normal, what are the odds they have coronary disease? It's still 99%. This goes to Bayes' theorem. Anybody familiar with statistics and Bayesian theorem and Bayesian statistics? It suggests that it should be applied to every test we do, but if you take 100 30-year-old housewives who all exercise, who come in and they present with sharp right-sided discomfort that comes and goes without any trigger, what are the how many of those 100 housewives are going to have coronary disease?
Maybe like 3%.
Yeah, 1 to 3%. I mean, not 0, but only 1 to 3. What is the chance if you take those same 100 housewives and put them on a treadmill and do a treadmill test, what percentage is going to have an abnormal stress test? No, dramatically higher. The false positive rate of women on treadmill tests is going to be closer to 30%. So you got a woman that comes in with chest pain. Now really you don't think it's coronary artery disease because you know that out of the gate it's only a 1 to 3% chance it is. So you're going to bet against it. But he said, well, just to be sure, I'm nervous. I don't want to be wrong. I'm going to order a stress test. So now you order that stress test. It's abnormal. And you go, shit. God, ooh, now what do I do? Now you got a patient that presented with chest pain. You did a stress test. Stress test is abnormal. What do you do? Now they're going to cath.
Now, you've got a risk of death.
There's a 0.1 to 0.2% risk of death, myocardial infarction, or stroke. So you just took a normal housewife who has 2 young children and a husband, and because you just felt compelled to order the stress test, you sent her to me and I killed her on the cath lab table.
So what do you do with that patient though? Because they're looking for an answer from you.
You
Just
reassure
give them
them. You reassure them.
Jeez,
You reassure them and you don't ignore them. You say, gosh, I don't think this is your heart. And then you think about other things it could be. Is it GERD? Is it Did she, is she carrying her kids in her right arm and pulled her pectoralis muscle? Is it pulmonary emboli because she's on estrogen and she smokes and she just had a long car trip? You think of other diagnoses and you treat those or refer her, but you see her back. You see her back in 2 weeks. And if the other doctors figure it out and she's all better, or it's gone away and hadn't bothered her at all, don't know what it was, don't think it was your heart, because if it's your heart due to a 99% LAD, it's going to keep happening. You see her back. Because if you don't see her back and then she has a heart attack, they went to see you for complaints of chest pain and you didn't do anything about it and you missed a heart attack. You're going to go to jail. So you reassure them that you don't think it's their heart. You look for other causes, but you have to see them back to see how they're doing, because there's 1 to 3% of those patients that you'll say, well, now I'm a little worried because now that sharp right-sided chest pain is going across the chest, it's radiating in her, she's short of breath, okay? Now all of a sudden, now I'm more worried. But if you don't see them back, you won't know until the lawyers call you, and then you'll know. So Bayesian theorem says that taking a low-risk population and doing a stress test on them, you're more likely to get a false positive result than a true positive result, meaning the stress test was useless to you. It didn't give you any more information and may lead you down a wrong path. Similarly, 70-year-old man, crushing substernal chest pain, elephant sitting on the chest, raining down both arms, short of breath, all the risk factors known to mankind, comes to your office, and you order a stress test, and the stress test is normal. Well, shit, what do you do next? Well, the patient has angina. You know there's like a 99% chance they've got coronary disease. They need to go to cath. Why'd you do the stress test? Did it give you any information? Did it help you make the diagnosis? No. And some lawyers would say, well, Prairie Cardiovascular just ordered this nuclear stress test in this patient to make money. This is fraud and abuse. We're going to review all their charts for the last 20 years and we're going to send them all to jail. Probably an over-exaggeration, but really it's about doing the right thing for the patient, getting that patient a normal stress test result because they've got balanced disease, coronary disease of their LAD circumflexing right is why they passed their nuke. They still have coronary disease, but now you're stuck with what's your indication for doing a heart cath? Because they have a normal stress test. Why are you doing a heart cath? Your insurance company would denied. We aren't going to pay for that heart cath. Why not? Well, because you did a stress test and it's normal. You have no indication this is normal. So be careful of just ordering stress tests to make yourself feel better. And again, that's Bayesian theorem that in high-risk population, doing a test is unlikely to change your diagnosis or outcome. So don't do it. Move that patient on to heart cath. And how do you document in that chart? Patient has typical angina pectoris, multiple risk factors in this age group. The chance of them having significant coronary disease is greater than 90%. The risk of complication with stress testing in this patient outweighs the risk of cardiac catheterization. The false positive and sensitivity and specificity of stress testing all leads me to be concerned that stress testing will be of no use and be a waste of money and time and may pose risk to the patient. Therefore, I'm ordering a left heart catheterization. That will get paid for, that will hold up in a court of law. It's the right thing for the patient. That's the way to handle it. In the same way, that young woman, you say, yeah, this is almost universally non-cardiac chest pain. We'll continue to follow up with the patient. Don't feel that stress testing is indicated here because the incidence of a false positive stress test is high and would then expose the patients to unnecessary cost and risk. We'll follow up with the patient and reevaluate. Boom, you're protected. Important stuff.
And I think just reiterating, especially nowadays with all of the insurance companies, because I've been called a few times when I've gone directly to heart cath. Again, it's just making sure the documentation in the chart covers that, like just how he had talked about, making sure that you talk about what are the symptoms, what are, why do you think they need to go to have the left heart cath, because I've been called and had to do peer-to-peer, and they want me to do a stress test, and then all I ask for is their name. And I say, that's fine, I will go ahead and order the stress test, I just want to document who's making the clinical decision overriding me right now. And usually that'll kind of help you get through. Sometimes, not always, it hasn't always worked.
And if you call your peer-to-peer review at 4 o'clock on a Friday,
yeah,
everybody's trying to get out of the office, they don't want to really discuss this or have a long discussion, so they'll probably say, yeah, do what you want.
yeah. It's all about timing.
Yeah. We'll move ahead here. So again, standard plain vanilla treadmill test with an interpretable EKG and ability to function is a class 1 recommendation. For patients who have an uninterpretable EKG, then you can do any test you want to do, class 1. Low pretest probability, that's the young 30-year-old housewife who do require stress testing because they come back and the chest pain's still there, you just can't figure it out, nobody else has been able to figure it out, you're concerned. Standard exercise EKG stress testing can be useful, that's a class 2A indication. And same intermediate to high pretest probability, which again goes back to Bayesian theorems. You can do stress testing in these patients with nuclear or echo as well. These are the big ones. Boom, class 3 means if you do this, you shouldn't get paid and it's malpractice. So if they have an interpretable EKG and at least one moderate physical functioning, and you order a nuclear test or a stress echo or cardiac MRI, it's class 3. These are the guidelines, and I know we all violate this every day, but at least now you'll be violating it knowing what the guidelines say. It's important. The guidelines might not be right, but that's the guidelines we have. Same here, that low-risk patients who have an interpretable EKG, again, class 3, nuclear stress tests are not recommended.
So, tell me the patient you would order a plain old treadmill on, like in real life.
Vanilla, you mean? Vanilla?
Vanilla?
Yeah, I would order a stress test. You see, I've played the odds too. So I got a 35-year-old woman who's got symptoms that I think is atypical angina. Well, then I'm going to use the odds in my favor. I know I'm concerned. I'm concerned she's going to drop dead, and then terrible things will happen. So I'm going to order a plain vanilla treadmill test on her. She's got a normal EKG. Because I know the incidence of false positive is going to be high. I'll get her to the cath lab and I'll prove it for sure. So I think they're really useful in that intermediate group who maybe have a lower likelihood of disease and who I want to get to the cath lab. I'll use it then because it's not a very good test. I mean, it's only accurate in women about 70% of the time. And it's a terrible test. But that's what the guidelines say. Yeah.
You think that sometimes you can use it to kind of prove to the patient that they
Oh,
can-
yes, because that goes back to what I said. Don't do that. Don't do that unless you're really backed against the wall. Until the patient says, "Oh, doctor, I really think this is my heart. I know you don't think it is, but I think I think it is my heart. My dad died at age 88 from a heart attack. I think I got the same thing, and I want a stress test." Well, I don't think it's indicated, and then document that. I don't think that this is patient heart pain. I've tried to talk her through this. I've tried to, but she is adamant. She's fearful, and that fear is causing emotional stress and preventing a good quality of life. And she's da-da-da-da-da. Then you feel that a stress test is appropriate, and then you can do it. But you also have to say that if it's abnormal, I'm going to send you to the cath. You got to be prepared for that. So think about your next step. This is angiography, so patients don't go to the cath until they have an abnormal stress test and are treated with guideline-directed medical therapy. Same thing, that's boring, you guys know that. That's moving on, coronary angiography, reasonable in patients suspected of disease who cannot undergo diagnostic stress testing or refuse or prefer not to. Then they can go on to heart catheterization. I think that's important. So if they can't do a stress test or a stress test isn't going to be of any value and the patient refuses to have it done, that can be done. Sometimes I'll tell patients, well, the accuracy of stress tests is going to be about 80%, which is really good, but 20% of the time we're going to miss something. So we may tell you that you don't have heart disease when you really do. And on the other side of the coin, if your stress test is abnormal, we're going to do a heart cath anyway. So, I mean, if you want to, we could jump right to a heart cath, which will give us 100% diagnostic accuracy, and will save you time. You don't have to come in for the stress test. Patients always go, "Oh, okay, I want the heart cath." So you can use this guideline to cheat the system to do what's right for the patient, and I'm always an advocate of that, but document why you're doing it. And it's not cheating, it's doing the right thing for the patient. And then when the stress test comes back positive, but your clinical, or negative, but your clinical suspicion of coronary disease is still there, then they go to cath, and that's a 2B indication. These are new, 2014, added to the guidelines. Well, when do I get to order the echo? We've been talking about stress testing and heart caths and treatment and EKGs. Echoes are fast, easy, low risk, low cost. They provide volumes of data, including valve, pericardial, aortic root, chamber sizes, infiltrative heart disease, LVH, et cetera, et cetera. This is a bargain. It's cheap, it's quick, it's easy, it's low. Everyone should get an echo who you're evaluating the off. No, here it is. You should only get an echo in patients with coronary disease or suspected coronary disease with known or suspected ischemic heart disease and prior MI, Q waves on the EKG, signs or symptoms of heart failure, ventricular arrhythmias, or an undiagnosed heart murmur. So don't just order an echo for chest pain because it's inappropriate. It's not to be done. In fact, the next slide clearly shows this. It's a class 3 to order any of these things just for chest pain. They've got to have heart failure, ventricular arrhythmias, new murmur, or Q waves on their EKG or previous MI.
Shortness of breath, though.
Now, shortness of breath is clearly concern for congestive heart failure. So, in the way, you don't want to be wrong, so you don't call it congestive heart failure, but you say dyspnea on exertion, worrisome for New York Heart Association Class 3 heart failure. Now, you aren't saying it's heart failure, but you're concerned about it, so that lets you off the hook. I didn't say it was, I was just concerned, and you get the echo. I mean, it's all about how you word it. This is another class 3, go to jail, don't get paid. Routine echoes every year. Can't do it, ain't gonna be paid for, and it's really malpractice to do, so don't do it. Yeah, I went through those. So here's the algorithm. Known ischemic heart disease, patient able to exercise, yes. Is the EKG interpretable? Yes. Then they go on and have their standard exercise stress test. And over here, if they're unable to exercise, they get their pharmacologic stress test. If the EKG is uninterpretable, they get their nuclear echo or cardiac MRI. Then what happens down here and over here? Special considerations: if they have left bundle branch block, they got to have a nuclear or an echo, which you guys will pick up in your stress testing lectures. Down here, do the findings suggest high-risk coronary disease? Well, they need to go to cath. If not, then you observe, you treat, you follow up with guideline therapy. Regular monitoring means you see them back in the office. Was it successful? Are their symptoms all good and all gone away? No, they're still having some symptoms, and most patients will. So then you send them to cath. But that's the approved algorithm, and it's a good one. You see nowhere in any of this algorithm, which is the official guideline for calcium scoring. So don't do it. We went over all that. Yep. 64-year-old female with known LV dysfunction, had a myocardial infarction in 82, CTO of the LAD, had a defibrillator, had a new RV lead put in after a lead recall. She comes into your office now with symptoms of chest pain. You got the old records. This is what you got, the old records. Good medical therapy, beta blocker, ACE inhibitor, aspirin, aldactone, Zetia, Zoloft, Ambien. Complains of dyspnea with exertion and fatigue, denies any chest pain. She's got hyperlipidemia, tobacco abuse, and maybe a little hypertension. Not bad. Those are her vitals. Any comments on that?
No statin.
No statin. Reason is she was statin intolerant, so she's on Zetia. Good pickup. What's your assessment of this patient? After everything we talked about, 64-year-old female, known coronary artery disease, known left ventricular dysfunction, on guideline-directed medical therapy. She's got dyspnea with exertion and fatigue. Those are vital signs. Do you want to ask any questions? You want a physical exam? You want to know anything more about her symptoms? Or do you just want to jump to a diagnosis?
I'd like more information.
What information do you want?
I want to know, is her fatigue and dyspnea any different than it had been previously?
Yeah, this is new. We're kind of vague on how often or when it started. But yeah, over the last 6 or 8 weeks, she's been noticing, and her husband say, yeah, she's about 8 weeks ago, doc, she can't keep up with me on the walks.
Okay. And any, like a shortness of breath when she's laying down, or like any orthopnea, P&D?
No P&D, orthopnea, or significant pedal edema. Great question. Why she asked that? She's looking for failure. I mean, it's dyspnea. Is this failure or is this angina? Tough to know.
Okay.
Last question that I would ask, are these symptoms similar to what you had when you had your heart attack? She don't remember. It was done in 1982. It's now 2013. I don't remember that. Or she'll lie and say it does.
What about consideration of PE?
Could be. She's been ambulatory, not on any estrogens, non-smoker, no other risk factors. Assessment?
And then I guess physical exam wise, if there's any change in physical exam, so she doesn't have any GVD, no new heart murmur.
No new heart murmur, no evidence of congestive heart failure on exam.
Okay. So then EKG changes.
No EKG. I think I got an EKG.
Yeah.
There's the EKG. She's paced, atrial pace, those are the green spikes. If you look here, you see Q waves here, poor R wave progression. You also see ST segment elevation in 1 through 5. What's that from? Well, let me ask you, do you think this patient had STEMI in your office?
No.
Or prior to CT overlay, right?
Yeah, so. All right, here's the question I'm really asking.
Can't diagnose.
What are the etiologies of what are the causes of ST segment elevation on an EKG? One, STEMI. I'll give you one, STEMI. You guys have to come up with the others.
Pericarditis.
PE, no. Pericarditis, yes. No. Intracranial hemorrhage or big CVA. Anterior ST segment elevation on the
You're
EKG.
communicating pretty well with her on that one, I'm not.
So that is another cause of ST segment elevation. The last one, anterior wall aneurysm from previous myocardial infarction, CTO LAD. She's got a big dyskinetic segment of her anterior wall, shows up as ST segment elevation on their EKG forever.
Chronically.
So those are the patients that roll in, they have a little chest pain, and we get called in for the star 90 or star 80, whatever you want to call it, it's dead heart, and we cath them, and everything's all open, they've just got an LV aneurysm. All right, so you've answered, what do you want to do?
Well, I would meet atypical angina.
I agree, I think this qualifies as atypical angina.
I'm trying to not use the word chest pain or.
What classification?
Go back again, you said 6 months, right, with heavy exertion, or with exertion, so,
Yeah.
so CCS class 2?
Yeah, I agree, 2 to 3. And I didn't give you much more information,
Yeah.
but really she was at 2 to 3, and I
Okay.
agree with that. So what do you want to do? I agree, that would be my assessment.
Well, I'd probably do and she can't exercise, so I do an exercise cardiolite study.
EKG is abnormal,
Mhm.
but she can walk and exercise. I think that'd be appropriate test. And I think that's a perfectly appropriate plan. The cardiologist who saw this patient did not agree with that plan and says really she's class 2. Some of her symptoms might be heart failure too, and they're class 2. Continue on with medical therapy, and they said follow up in 6 months. I can tell you by guidelines and all that's not inappropriate. I mean, you caution the patient, call me if there's any change or any accelerate. This would be a conservative approach, but it would be defensible to follow up in 6 months with this patient. I don't think it's wrong. This lady, she's not that active anyway. She's just complaining a little fatigue and shortness of breath. She's not making a big deal of it. She's just following up. 6 months seems a little bit long to me, but that's style points. Style points.
You wouldn't do a checker LV functioning for shortness of
You
breath
could.
on exertion?
You'd have to say dyspnea, known left ventricular dysfunction, known myocardial infarction. I'm worried this is congestive heart failure. You do it. I think that would be reasonable too. Yeah. They didn't. And the reason I'm going through this is to make you think and also see how a prairie cardiologist has handled it. Wasn't me, by the way. So that was the EKG. Ultimately, the patient got worse and had symptoms and had a heart catheterization just a few months later. This is the right coronary artery. You see a critical lesion right there, another secondary critical lesion in the mid-segment. Pretty good flow out into the distal right coronary artery. This is the left coronary artery, the left main is normal. And what you're missing here, you see filling in late right here, see the calcium? This is her LAD right here, it fills in late by collaterals. So she's got a very proximal left anterior descending artery chronic total occlusion, which we knew about by history. The rest of the vessels you see here are circumflex and it's supplying collaterals. She went ahead and got PCI, put a stent in here, got a really nice result, and did well with that. Was seen back just a few weeks after her PCI. The only medication change was the addition of Plavix. Vitals are still good. Questions?
Did you notice a difference?
Feels much better. Her symptoms have all resolved. Fatigue's going away. She's more active, less shortness of breath.
So that was her anginal equivalent.
I believe so. Assessment? Don't make this hard. She's got coronary disease, successful PCI, symptom resolution, on all guideline-directed medical therapies,
Yeah.
no CHF, blah, blah, blah. Plan?
I would, again, it's just style. I would
Excellent
probably,
plan. It is style.
I tend to follow up with them post-PCI. I'll usually follow up with them, the 1 week after, and then I usually do 2 to 3 months after,
Yeah.
just to make sure.
As an interventionalist, I would see her 2 weeks after PCI, then 6 months, and then 1 year, and if they're doing well, then yearly. Style points. There's no guidelines to direct us on that. But that's all. So this cardiologist wanted to see her back in 1 year. So that was January 14, want to see her back in a year. So she come back in February 15, scheduled follow-up, no change in her medications, heart rate, blood pressure, all unchanged. Any questions?
Long-term, do you want to check with therapy?
Check what?
Long-term aspirin Plavix?
Yeah, that's a question. That's yeah, she's had a year now. It would be appropriate to take her off her Plavix and continue aspirin. Good one. Anybody have anything else?
How's she feeling?
She's feeling good. Feeling good. So it's a well baby check, right? So she's got stable ischemic heart disease, stable coronary, stable heart failure. She's on all appropriate medicines. Keep doing what we're doing. See her back. I'd see her back in a year. Well, then she came in because on her routine defib check, she had 3 episodes of non-sustained VT. This is 1 month later. Was successfully treated with anti-tachycardic pacing. She's been no change in her medications. I can tell you her lights and everything like that were all normal. Her vitals are all normal. Any questions on that?
Oh, I hate
So
those.
would you consider intervening on her CTO since she's now having VT?
That would be planned. We're waiting for questions. You want to know anything more?
I just, at your last CAP conference, I was.
How's she feeling?
She's feeling fine. Feeling pretty good. Maybe a little fatigued. She's a little lady. Yeah. Well, if you really push her, she'll tell you whatever you want to put in her mind. You aren't any more shorter breath with activities, really? Well, yeah, maybe. This is real life. This is what they say.
Now she has 3 new episodes of non-sustained VT, which was treated.
Which is a change. All right.
But what's the cause?
Exactly. What's the cause?
What's the cause of
What's
that?
the cause of that? Yeah. So you're concerned.
Yeah. So.
So what do you want to do? So we all agree this is a change. She's got new VT.
Yeah, we're gonna call EP. We're gonna call EP.
Maybe check some labs.
See, this would be the wrong
He said
answer.
electrolytes were
EP's
fine.
no help here. They've already put the defibrillator in.
Their job's done.
Char's right, something has changed.
Your job's
Something has
done.
now caused her to have VT in which she hasn't had before. It can't just be her first time. That happens. But you gotta look for causes. I said the lights were normal, so she's not on all her aldactyl and everything else.
So we'll have to
Her
do-
case not 7.
We have to do some type of ischemic workup. The
I-
question is, this is where I get a little
Well, if they've
anxious.
had VT, then
Yeah.
you can do an exercise test, right?
Well, no, you can't, well, she's had VT, so we're not gonna,
Stressor.
I don't know. This is where I get anxious with the treated VT. So, I don't know if I would do a stress test or if
Her
I would-
cardiologist says, and I quote, the etiology of the arrhythmia isn't clear. It is a
Okay.
new change. She has had a history of coronary disease. I'm asking her to have a nuclear stress test to rule out any myocardial ischemia as a cause.
Yeah.
It's well documented, it's well thought out, It's approved in the guideline. I think absolutely stress test here is appropriate. If you said, oh my God, she's got known disease, she's got left ventricular dysfunction, she's a high-risk patient, now she's having VTI on her cath,
Yeah.
yeah, I can document that and make that work too.
Yeah.
So I don't think that's wrong. Ignoring her, sending her EP, saying I'll see you back in 6 months, those are all malpractice. So she had her stress spect on 323.15. It was pharmacologic, should have been exercise according to the guidelines that Reggie Dennis on has
I didn't
done.
think so either.
She's got a large infarct of the anteroseptal wall, we knew that, and she's got a moderate sized infarct of the infero-apex, which could be from the right, could be from the LAD. Her EF was 39%. What do you want to do with the stress test?
Well, there's no ischemia, it's fixed, correct?
Yep,
EF is.
that's the way it was read out.
Yeah, and EF is.
Low. I mean, she
Stable.
was 35, now she's 39, so probably within the...
Viability study?
That's a good thought. It's a real good thought. Any other thoughts? Well, she was seen back in follow-up just a couple weeks after that. Again, no change in medications, vitals are all stable. And the impression and plan from the cardiologist, Carol developed non-sustained ventricular tachycardia, weakness, fatigue, and tiredness. Although she didn't complain of that prior to in the evaluation, wasn't documented. So it kind of lets a little fudgy in here. But this is real. She had an abnormal stress test showing infarction and peri-infarction ischemia. The stress test interpreted by the same cardiologist order does not mention anything about peri-infarction ischemia, because I know if it had, you all would have said center heart cath,
Right.
which would have been appropriate. Her stress test results, and I have it here, does not mention anything about ischemia. So that, just be honest in the
Yeah.
chart. Based on this, I've recommended her to undergo a viability study to determine the appropriateness of CTO PCI. Other than, and maybe she had all these other symptoms, and maybe there really was peri-infarct ischemia. It's just not documented prior to the decision of sending her for a viability study. I can throw stones at that. She had a dobutamine echo, which showed infraapical viability, which improved contractility of low-dose dobutamine, a definition of viability. So the infero-apex is viable. The anterior segments were deemed non-viable. So now what do you do?
Well, inferior apical, we'd be worried that maybe restenosis then of the.
Yeah, or is it a big wraparound LAD that
Right.
supplies it? Don't know. Don't know.
Well, now you've got to live with the test.
Exactly. God, it's
Now
like
we-
you've been to this lecture before. Now you got test
I work
results.
with John Gill.
And you got, exactly.
Standard.
Us old guys all
Yeah,
feel
you
the same.
guys, you guys are all, so yeah, you're gonna you have to live with the results of the test, so you have to go take her to the cath lab now.
So we're going to Catholic.
That's what I would do. This cardiologist said her symptoms of angina, heart failure, and decreased energy have all resolved. This is on follow-up. Did I put that in? Oh, I gave it away. Have all resolved after, no, wait, let me make that. She did go to the cath lab based on this. I apologize. She did go to the cath lab, which is appropriate. So this is May of 15. Again, her LAD's missing. You see it ghosting in, but this is the CTO, the LAD. The circumflex left main are all the same. Here's her right coronary artery, instant restenosis in the mid segment. You can see the stents in there before the dye gets there, about a 99%. Underwent balloon angioplasty of focal instant restenosis in the mid stent. Even Don would say, yes, pretty good result, happy with that. Got out, did well. Followed up a few weeks later after PTCA of the instant restenosis, no change in medicines. And we'll speed up here. Cardiologist, her symptoms of angina, heart failure, and decreased energy level have resolved after successful PCI of the right coronary artery. Follow up in.
Oh,
6 to 8 weeks for sure.
This cardiologist said 3 months. I don't know why he made that change. Why? Because he had been 6 and 12, and now is he a little nervous? I don't know. But he saw her back 3 months time. So now we're in September. Scheduled follow-up. I'm not going to play the game much longer because we're running short on time. Symptoms of angina and shortness of breath have improved after stenting. No new symptoms. Follow-up in.
Would her device show anymore?
Device, all device checks have been stable and good, so she had no. So the diagnosis of her VT, which was new, good teaching point, was ischemia due to restenosis. You all were thinking, good job. He's already back in 6 months, so he's okay. I feel good. After 3 months, she's better. 6 months, she's better. So now let's see her 6 months. This is the scheduled follow-up in November. She denies any symptoms that suggest CHF decompensation or angina. She does have dyslipidemia, but is intolerant to statins. I will give her information on PCSK9 inhibitors. I think that's appropriate. Very appropriate note, very appropriate plan. See her back in 6 months. Her device was interrogated, appears to be working well, no new problems. Her LDL, by the way, is 250. Zetia ain't doing diddly squat.
We need that weekend, yeah.
Unscheduled visit because now her defibrillator is discharged. Amazing she didn't go to the ER, right?
Of course not.
I mean, she went out. She said she felt, I'll skip it, the question you should. Well, what symptoms did you have right before that defibrillator hit you? I mean, had she had 20 minutes of crushing subterminal chest pain or shortness of breath and fatigue? Had she been having some? No, I kind of felt dizzy for a few seconds and boom, they went off. Well, that's because you were in VT and were dizzy because you were dying. Anti-tachycardic pacing did not work, so she was successfully defibrillated with one shock. So what do we do now?
Well,
I think with her history, I would stress her, and I would take her right to the cath lab.
Yeah, I think stress testing in this case at this time with this patient's history would be wrong. And the cardiologist says since this is her second episode of ventricular tachycardia and there's evidence of hibernating hypoperfused myocardium and suspecting ischemia as the trigger of arrhythmia, I'm asking her to see our CTO interventionalist, that's all I know in this case, for reevaluation or possible revascularization of a chronic total occlusion. Here's our EKG. They did do another EKG as appropriate. Still, you see the SC segment elevation here, and I think that's a good teaching point in this patient with a large anterior wall.
So that'll never go away with her?
Never go away. She'll always have it.
Okay.
But no other changes. She's paced, and there's nothing else on her EKG. They did get an echo, and EF is down, but we all, you know, you can do 10 echoes and have 10 different cardiologists read them, and we're all going to come up with different numbers, so don't put a lot of stock in it. Here's our heart cath. The right coronary artery is now occluded in March of this year.
So why did that cardiologist not just go right to the cath lab instead of sending her to you to check out the right and first?
His feeling was that she hadn't had any significant change in her symptoms. She just had VTVF. It was due to ischemia, due to her CTO. So he wanted her to be like.
She's had VT from the right before.
She has. Yeah. But with that, she did have some symptoms, according to his notes, and this time she didn't. But sending her to me gets her to the cath lab, usually. So she now has a total occlusion of her mid-right coronary artery right at the stented segment.
And this is where the instant restenosis is happening, correct?
Mm-hmm.
What kind of stent?
Her LAD, it was a standard, I think it might have been Medtronic Resolute.
Does it matter what kind of stent she had when she has an LDL at 250?
LDL does not cause restenosis, so her mechanism of this occurring is due to restenosis of a stent, which has nothing to do with diabetes, antiplatelet agents, or anything else. This is scar tissue formation. And we know that balloon angioplasty for in-stent restenosis is effective with a restenosis rate of about 30%. And it was felt at the time that putting another layer of stent in would have posed more risk down the road, and I would agree with that. This was a very focal in-stent restenosis. Using a high-pressure balloon and getting a good result is probably the best way to go. Otherwise, you start having layer upon layer of stent. Unfortunately, usually they come back just with restenosis, and then it blocked off again, we'll put a stent in. She came back with a complete occlusion, which is rare, but happens. So. This is her LAD, still occluded, The difference here is now you see the collaterals filling her distal right coronary artery. So now her left main and left circumflex supply collaterals to her anterior wall, which is dead by viability study, but also to her inferior wall. That's the other view that you guys really don't care about. So what do you want to do?
Fix the right.
Center for cabbage.
That's what I'm
I said,
saying.
they're finally getting to you, Amy. So
Yeah. Center to cabbage, why?
To,
Center to cabbage for what? What are you
For
going to ask the
what?
surgeon
So-
to do?
for a lima to her LAD,
Why? It's non-viable.
but it's providing collateral flow.
No, circumflex is providing the collaterals. Good thought. And I would say if she centered to cabbage, you'd want an IMA into the LAD and a saphenous vein graft to the right.
To the right, right.
Well, then saying that, well, but the LAD provides collaterals, we want to bypass. Well, no, because
But
we're
now the
bypassing.
right's bypassed, right? Okay. But putting.
But I think saying her cabbage is reasonable. I think it's reasonable to have surgeon look at her. I think it's reasonable to open up the CTO with the right. As a CTO guy, this is an easy CTO for me to do. And I'll IVUS it and put it in the stent, and still a long-term outcome is good. Any other thoughts?
Well, let me ask you, what if you couldn't open up the right?
Mm-hmm.
Would you try to open up the CTO of the left, or?
Yeah, I kill people with CTO PCI.
Yeah,
So
no.
if I really don't think it's going to help her, I'm not going to expose her to the risk.
Right.
I leave that LAD closed. It
Would you?
was
Okay.
good study that was done, shows it's non-viable. When the
Right.
right's open, she doesn't have any symptoms of angina or failure.
Right.
Am I going to make this patient better by opening up their LAD? I can't tell her that.
Yeah, okay,
So I would not.
okay.
So this is, obviously I don't know a whole ton about CTOs, but if she's already had a couple stents in the right, restenose,
One step.
okay, one. What makes you feel good about putting a line in there?
Well, putting a line could put one more. That's a good question. So what I do, this was a couple days ago. I sent her to see a surgeon. I said, I can open up that right. I'll use IVUS, which wasn't done on any of the other two times. Maybe this is a 3.7 millimeter vessel and we're putting 2.5 stents in. Maybe that's why she keeps restenosing. Mechanism restenosis is important. And then I'll put a drug-eluting stent and I'll optimize the results with IVUS and get a perfect result. I can do that, and she'll do well.
So you send her to the surgeon,
I
get a
sent her.
consult?
I told her
You
that
give
I
her
can do
both
it.
options and-
I said, because you have a CTO of the LAD, because you have left ventricular dysfunction, and because you've already had documented restenosis twice of this right coronary artery, I think we can talk to the surgeons. If she would ask me, well, what would you do, doc? I'd say, well, I think your entire anterior wall is dead, so I think opening your chest to put a bypass into that will not help you at all. And you'll get a vein into your right coronary artery, and 50% of saphenous vein grafts are occluded at 10 years. She's only 64.
Right, she's young.
Then I'm back to dealing with the CTO. I'd rather fix the CTO now. And I would tell her, and if I can't get it open, there's a risk, major adverse cardiac complication, about 1% perioperatively. So assuming that doesn't happen, but I can't get it open, I can always send you to cabbage, single vessel cabbage. But in the heart team approach, I think it's very appropriate to have the surgeons talk to them. And they'll talk, what's their risk of major adverse cardiac event with surgery? Cabbage. What do the surgeons quote our patients? A 64-year-old patient without diabetes, without previous stroke, without acute kidney injury. What's her
With
STS?
significant left ventricular dysfunction, a little bit higher risk than normal,
Yeah.
normal 1 to 2.
Put a number on it.
Put a number on it?
Yeah.
My STS risk calculator, I would have to
Yeah, ballpark it.
5-6%.
I agree. I think most surgeons probably tell them 2 to 3. But
She's probably 5 to 6.
But if you run it through SDS, it's probably 5-6. I can tell you from our Prairie data, her risk of major adverse cardiac event perioperatively with CTO is about 1%. But I think it's appropriate for her to hear that, and then we can say, well, your risk of surgery is 2 to 3, maybe 5 to 6. The risk of CTO is 1%, and we can always go back and have surgery done if I'm not successful. I think that's appropriate, but I think it, medically, legally, you got a patient with bad pump, 2 CTOs, little old lady. If you don't talk to a surgeon, you look like a cowboy. And if something bad does happen, there'll be somebody throwing a stone at you. And not that I can't stand up for myself, but I don't, there's no hurry. They're both occluded. They aren't going to get any worse. So walking the patient through the process, getting the surgeons on board is appropriate. Now, I will have to live with the fact if the surgeon says, no, I can do this 2% risk and I'm going to get both vessels, Dr. Hall's only going to get one, and the patient, well, I want cabbage. I got to live with that, and I got to trust my surgeons who I'm sending to, that they look at the viability study, they talk to the patient, they put it all together, but those are kind of things that are out of my control.
But that's where the team approach is good, because then you and the surgeon should be talking to each other.
Should, but you know that doesn't happen
I do.
in most cases. Yeah, but it should be. But I all in all, this whole case study, I think, is stuff that's bread and butter that's done every day. And we went through 2 years, well, not 3 years of patient visits and thinking through things in a patient who has complex coronary disease and left ventricular dysfunction, kind of atypical anginal symptoms that you put together. You know, when do you do the stress test? When don't you? She's complicated with VT and VF and da-da-da-da-da, and then surgical versus coronary thing. So I really came across this case and I thought, gosh, this has so much stuff in it that this is a good case to talk about, and I hope you found it useful for your educational purposes. Any other final questions?
Oh,
Yeah.
I had one thing, at ACC last week, they talked a lot about the coronary calcium score and the CT.
Yeah.
And they made comment, which I had not previously really wrapped my head around thinking about that, but the reason why it's not a great test for our younger patients or more high risk is because it doesn't show that soft vulnerable plaque, it's just that calcified hardened artery. So those plaques that are more prone to rupture don't show up on the...
Let me put it this way. Let's say a 45-year-old patient, male, female, doesn't matter, comes in, got a family history of coronary disease, they're a smoker or used to smoke, a little bit of hypertension, bad lipids, not a diabetic. What are you going to do for that patient?
Are they having symptoms?
If you really push them, maybe, but not. You don't think anything.
They're high risk, I'm on an aspirin.
Okay. You going to do anything else? Let's treat their blood pressure.
Yeah.
Okay. Their cholesterol's high. Let's put them on statin. So we're going to do that. Same patient comes in, and they say, my doctor had me go get this coronary calcium score. And the coronary calcium score is 100, 200. We're going to do that patient now. I don't know, aspirin, control their blood pressure, put them on a lipid, diet, exercise, stuff like that. Coronary calcium score is not going to change your plan. It also gives patients a false sense of security. That 40-year-old, oh, my coronary calcium score is normal.
Yeah.
Boom. Well, we didn't look for soft point.
Exactly.
And in the same way that the 80-year-old patient, they're all going to be positive.
They're all going to be high.
They're all going to be positive. This is why it's class 3 to order coronary calcium scores right now. Now, we may come up with new data that we can find a niche where it is going to be helpful. I don't think so. I think it'll be coronary CTA that will be useful. But coronary calcium scores are great marketing, but of no clinical value. Oh, you got positive. Well, you should be on aspirin and control your risk factors anyway.
Yeah.
But in that way, it's good. I mean, I'm making fun of coronary calcium score. It does get patients into their primary care doctor's office and into our offices such that we can start risk factor modification, which is hugely important.
Right.
And they paid $40 for it. Whatever it takes to get patients in so we can start treating them early, I'm a fan of. But from a medical standpoint, boy, you guys should don't suggest or recommend anybody have a coronary calcium score, because it's really not. You recommend they get in and see their doctor and have their lipids tested and their A1C tested and their blood pressure taken, and they quit smoking and they start exercising an hour 6 times a week, whatever the recommendation.
What about the coronary calcium score in a 40-year-old that's 600 though? Would you be a little more worried about them, or?
I don't know. I know the coronary calcium score is 0, they can still have a heart attack. Coronary calcium score is 600, and they can still have a heart attack. And What would you do? An asymptomatic patient, multiple risk factors, coronary calcium score 600. What do you want to do now?
Guidelines say stress test if it's above 400.
Yeah, can. And you're going to send them a heart cath. And I can tell you, I've done 600 calcium score heart caths, and some of them are completely normal. They just got calcium, Monkbird's calcification. I've also done patients with coronary calcium scores of 1200, and yeah, they had left main triple vessel disease with completely asymptomatic. So I felt good about it, but I also know that I can kill people. And all these are great points, and the fact that you're thinking about it. What if, and you think about okay, am I going to send them to the cath or am I going to stress them? That's all good. And you should take each patient individually. Guideline-directed therapies are population-based therapies. It's good for the population in general as a whole. For an individual in that population, it may be absolutely the wrong thing to do. And you got to take that into mind, that these are guidelines. So if you think your patient is really high risk and maybe they're stoic and not telling you about symptoms and their calcium score is 600, I'm going to do a stress test. And I think that's right. But I would also tell you that same patient comes in and I think they're stoic in the symptoms, but I get a feeling, we could talking to the family, oh, he's not doing as much. I might do the stress test anyway. Most of the time, a coronary calcium score does not change my management plan. And if it doesn't change my management plan, I don't do things. I don't care if it's a CBC, a BMP, stress test, heart cath, echo, any test. I apply the Bayesian theorem. It's not going to change my plan. I'm not going to do it. It's about taking information in. So I'd be cautious on coronary calcium scores. But they're ubiquitous and we have to know how to deal with them. And I'm not saying my way's right. In fact, you're thinking about the individual patient and taking that piece of data in and making the test fit the patient, not the patient fit the test, is absolutely correct.
Do you feel like we have to do something though? Let's say primary orders the cardiac calcium scores. And
You did do something. You got to start it on guideline-directed medical therapies. And I often will tell patients, your calcium score was positive, which suggests there's a high likelihood that you do have coronary artery disease. But you don't have any symptoms, so I'm going to treat you medically. Aspirin, beta blockade, statin, sublingual nitroglycerin, risk factor modification strategies and stuff. And I feel good about that. When I get the primary care doctor sends me a patient with a calcium score that's above 0, I feel good about that because I can tell the patient they probably have coronary disease. Now, they may have some clinical coronary disease, but we're all Americans. They're going to have it sooner or later, and I get to start therapy early, which is probably, as long as you keep it with simple stuff, is going to help the patient, not hurt them. And I think that's really important.
Hey, any suggestions? I have a primary care doctor in an outlying facility who loves to do vanilla treadmills. And then when they're abnormal, ask me them. But he sent me 5 and 4 of them have had normal caths.
Yeah.
How? And I'm an NP, remember?
Yeah.
So I can't tell a doctor be more discriminating about who you stress. Just don't, I don't know.
You're being forced to live with the results of somebody else's test, which, as an interventional cardiologist, I'm often put in that same role, and it's no less awkward for me than it is for you. And you got to look back. If the patient has no symptoms and low risk factors and in that low risk score, and their plain vanilla treadmill is abnormal, well, I'm not going to rush them to cath. Now, I'll evaluate them myself and maybe then you say, well, then you send them for a nuclear stress test. And then you reassure the patient that you've had 2 types of stress tests. Both are normal. We don't think this is your primary care doctor will be happy with that.
Okay.
But if they're in a higher group, I think you're forced to take them the heart cath because everything was done appropriately. And it's just the vanilla treadmill tests aren't very good. But it's good to tell somebody they have a normal heart cath as long as you did it for the right reasons. And don't feel bad about that. You're doing the right thing for the patient. You're dealing with somebody else's test, which you can throw stones at, but as long as they did it appropriately, it's good. You made money for the interventional cardiologist. We love that. And I tell you, telling a patient they have normal coronary arteries is good. They feel good about themselves. You get them in your office. You can follow up with risk factor modification. Also, their insurance rates won't be affected.
Okay.
If they have an abnormal stress test and you don't cath them and prove they're normal, now they've got a pre-existing condition of coronary artery disease because they had an abnormal stress test and their rates go up. But if they have a normal heart cath, they can submit your letter from the office, no coronary artery disease definitively, their insurance rates don't go up.
Okay.
And that's important, really important.
Yeah, I hadn't even thought about that.
Yeah. I like telling people they don't have coronary disease. They feel better. Their children, now they don't have a family history of premature coronary disease, so they feel better. Everyone feels better. It's good stuff. All right, see you 7th for ACS.